University of Nebraska-Lincoln, med school at UNMC in Omaha. Then I left for 5 years, went to Royal Oak, Michigan in the Detroit metro area, one of the busiest orthopedic hospitals in the country. I spent 5 years there, and then I went and trained with a guy named Anthony Headley in Phoenix, Arizona. Kind of a legend, been doing it for 30 years. He's produced about 70 different fellows like me. I come back to join Miller Orthopedics in Council Bluffs in Omaha, and obviously we come here to help out as well. My specialty is hip and knee replacements, reconstructions, revisions, all that kind of stuff. Hip and knee arthritis and everything that goes wrong with arthritis is what I specialize in. So, what I was going to show you today is a PowerPoint. First, hips and knees we'll talk about. First and most important thing to know is arthritis isn't a normal thing with aging. It's not. People live to be 90 years old and they don't have any arthritis. It's not normal. Some people think there's a genetic aspect to it. Some people think that the wear and tear over time. Some people think that heavy weight, all these different things add to it. We don't know for sure. Some people are just unfortunate and need somebody like me. People come in with a multitude of complaints, and the first step is to get a correct diagnosis when you're doing that. I'll see people all the time and they'll have all these MRIs and all these scans and all this kind of stuff, and most of it, to be honest, if it's arthritis, none of it's necessary. All I need is to see you, examine you, and a simple x-ray. If your arthritis is bad enough to need someone like me, that's all you need. You don't need anything more fancy than that. People come in and they'll say, my hip hurts, and they'll be pointing back here. Or my hip hurts, and they'll be pointing down here. True hip pain is right here in the groin. That's where your hip joint hurts. Now when it gets real bad, you can have lots of other symptoms. It gets real bad, you hobble too much, your back will start hurting, that'll shoot pain down your leg. Lots of different things. So, hip pain is a common thing to say. Hip pain isn't necessarily what you'll need when you come see me. It could be. Could mean that you need something from me, but it could mean you need your spine worked up, could mean you need therapy, could mean all different kinds of things. Same thing with knee pain. Knee pain can come from your knee. It could be shooting down from a different area. Could be something on the lower end coming up and affecting your knee by how you walk. Don't know that till I get x-rays and examine you. So, I know a lot of people show up to clinic knowing what they need. That's not necessarily true until we have all the information. So correct diagnosis is very important. Once you have a diagnosis of arthritis, there's lots of different stages to it. There's early onset arthritis. It means that you don't have too bad of arthritis on x-rays, you're just starting to have some pain, nothing looks too bad. Well, we start doing things like physical therapy. We have you take ibuprofen and over-the-counter NSAIDs like that. We have you do injections. There's steroid injections. There's what's called viscosupplementation. That's like a gel. There's all these kind of things that we can do over time to try to help you with pain and get you over the hump and get you back to your daily life. Now, if we try all these and things keep getting worse and your arthritis is really bad, there is no cure for arthritis. Everything is pain control and a Band-Aid and strengthening your muscles around it to stabilize everything to make you feel better. But in the end, we can't cure it. It only gets worse. That's the way it works. So once you hit the point nothing else is working, or it's so bad that nothing else is going to work, then it's time for me to step in as a surgeon and give you a new knee or a new hip. There's lots of different things you hear about with hip and knee surgeries and different options and things you'll read about on the internet and see TV commercials and all that kind of stuff. Knees, you have options between partial knee replacements, total knee replacements. Hips, same thing. There's people that advocate for these resurfacing things, which I personally do not do. Then they argue about how you get to it. Anterior, posterior, multiple different options. The truth of the matter is, if you have a good surgeon that does something they've done for a lot of years and they have very good results, they're a good surgeon, period. You're going to have good results. The new idea now, though, is to do as much soft tissue sparing and avoiding dissecting as much as humanly possible. So you get up and move faster after surgery, you get out of the hospital right away after surgery, everything goes wonderfully. So I do a couple things different than most of the people in the area. When I'm doing a total knee replacement, I do what's called the subvastus approach. That means that you, instead of cut through the tendon of the quadriceps, you move the tendon out of the way. In my experience, in my opinion, I think people get up and move much better than that, than the other way. I think they get up faster. You still have pain after surgery inevitably, but I think people get up and move even faster. Hip is even more of an argument. People will come in and say, I want the anterior hip, without knowing what that means, or I want this hip. And the truth is, they've all been ways of trying to not cut through muscle. There's the old school approach posteriorly where you open up the whole femur. That doesn't really exist anymore. Now, including one of my partners, they'll do what's called a smaller muscle sparing posterior approach. Same idea, just a smaller incision, and you spare as much muscle as you can. Anterior approach is the same. The idea you're splitting muscle and you're going down and to the hip without cutting as much. But the truth is, in every hip procedure like that, you end up cutting through some muscle. You end up taking off what's called the external rotators of the femur. You're looking right at them posteriorly, but you're not anteriorly. You're cutting them through the capsule blindly. And all these rotators are called your obturator internus, your superior gemelli, inferior gemelli, quadratus femoris, and the most important one is your piriformis. These all help with stability of the pelvis. They help you rotate your hip. They help with everything. Well, the approach I do is different. It's posterior, but it's called the direct superior approach. So instead of an incision from here to here, you get a small one from here to here. On a normal sized person that's not large, it can be 9 to 10 centimeters. That's it. That's less than 4 inches. I go down, instead of cutting your big strong IT band on the side of your leg, and instead of cutting through a bunch of muscle, I just split your gluteus maximus, your butt muscle fibers, and just split them until I get down to the hip joint. And then once I'm there, I save that piriformis muscle. I save all of those rotators except for one. There's a conjoined tendon that joins that muscle called the obturator internus. It's the only tendon I take down. It allows me to do a different type of capsulotomy. I get deep retractors in to hold everything in place, and I can reform your hip through a very small incision with hardly dissecting any muscle. So, what do I think it does? I think people get up faster. I think they move faster. Theoretically, the risk of dislocation is lower because I'm not taking as many things off of the femur. It's all beneficial in my opinion. However, you have to qualify for that type of procedure. Can't do it on everyone. I can do the same muscle sparing approach on everyone, but some people don't get an incision like this. Some people have a normal incision just by the size of the person. It's inevitable. It's inevitable. When you make a skin incision on some people, I know we like to say that we're big boned. That's not a true statement. If I'm going through that much fat before I hit any muscle or tendon, I can't do it through an incision that big or everything collapses on itself. So you have to open things up more to be able to properly do the surgery. The most important thing is your final outcome and the fact that you spare your muscle. The skin incision, we've cut ourselves since we're children. We heal that just fine. But it is fun to show your friends that you have a smaller incision than them, when possible. The whole idea is the less you cut, the less pain you have, the better you do after surgery.